The doctor is in. How are you guys tonight? I have a great show planned. We're hoping that Mo joins us. We don't know where she is at the moment. She's probably in surgery since I didn't hear from her, but I have to look at this great panel we have. I love it when we look like the Brady Bunch. And but I have like these awesome people to talk to us today. Our topic today is stage 0 breast cancer. Stage 0 breast cancer. So let's go and everybody introduce yourself, and then we'll kind of get into this conversation. We'll get Dr. Lena to kind of tell us what that's all about. But Dr. Lena is on our medical advisory board, and I haven't seen her for a while. It's so good to see you, my friend. So I want to give a 2-second introduction. We'll just go around.
So I'm Lena Romero. I'm a breast cancer surgeon. I was the former director of breast cancer surgery at Kaiser Los Angeles, and now I'm also a breast cancer survivor.
Awesome. Gwen
McKenny, and I am a breastie to all of my beautiful sisters on this in these boxes, and I am a breast cancer survivor of DCIS, and in January it will be 1 year.
Awesome. Tish.
Hi, good evening. Tish Harrison. And this past February, I celebrated 5 years as a survivor, and am happy to be here.
Christina.
Hi, my name is Christina Miner. I am a breast cancer survivor of 2 years, and I'm so glad to be here with you all as well tonight.
I'm so loving all this breasty love. And Heidi.
Hi, I'm Heidi Senior. I am a 5-year breast cancer survivor as of August of this year, and I am happy to be here.
I love it. I know every day is a blessing. Every day, right, you guys? Every day is a blessing. So, wow, all this breasty love. So let's talk about stage 0 breast cancer. We know there are 4, but really 5 stages of breast cancer, right? And we know we don't want to go to 4, but what is stage 0? And what does that mean, Dr. Lena? Can you explain that to us, please?
So Ricky, you're making us confused by saying 5 stages, right? Because we all think of stage 1 through 4. But that's exactly the point. Stage 0 breast cancer is the earliest form of breast cancer. There's actually some debate as to whether it should be considered a true cancer or whether it's a precancerous state. But regardless, I think the reason that we consider it a precancerous state or a cancerous state is to make sure that people take it seriously and they get it treated, right? So DCIS is stage 0, and what that means is it's ductal carcinoma in situ. And so ductal carcinoma in situ means that the cancer cells are contained within the breast milk ducts and that they cannot get out. And so the reason that it's considered a stage 0 is that usually if we think about a cancer cell, we think about cancer cells growing and being able to move into blood vessels or being able to move in the case of the breast outside of the duct. But by definition, ductal carcinoma in situ is contained within those ducts. It can't get out. And so then the good news about DCIS is that it cannot turn into a stage 4 cancer. It can't progress to stage 4 if it's taken care of in stage 0. Does that make sense?
All right, so here's a crazy question. I always ask you to talk to me like I'm a 5-year-old. What else is in a boob besides a milk duct? What else is going on in there? Like, where else?
So if you think about it, think of it like a bunch of grapes, right? So the stems of the grapes or a bunch of grapes is the duct. And then the grapes themselves are the lobules. And so the lobules are what make milk when you're lactating. So you have ducts and you have lobules. And so again, if you use the bunch of grapes analogy, the ducts are the conduits, right? Like the stems. And then the lobules are more like, like a fluffy, it's the gland really that makes the milk. Does that make sense?
Yeah, that helps a lot.
Yeah.
So when it's in milk duct.
Yeah, some of you may have heard of lobular cancer. So when you talk about lobular cancer, the difference there is that that's from the lobules, the breast lobules, rather than from the ducts. So they're from the grapes rather than from the stems.
Right. Yeah, we're actually going to do a show on lobular next week. next week.
Oh,
So we'll
there you
have, and so thank you for that. So that's great. So it's really very early stage. And, my mom had stage 0 and they wanted to tell her, don't do anything. It's okay. And she's like, well, bring everything. I want it all. Like, what are you going to do? And she ended up having a lumpectomy and radiation by choice. That was
Right.
like, 25 years ago. So I think it's changed. So let's call around because, I think everybody came to their decision about what treatment to do from different perspectives. So I'm going to love this conversation because all of you guys chose different things, had different information, and made your decision to do what you did from a different perspective. So who wants to go first? Tish, will you go first?
Yeah, sure, I will. So I was diagnosed in December 2016 at the age of 36. At the time, I was supporting my best friend who was like my sister through her diagnosis of stage 3B triple negative at the time, like a couple of months after she had had her baby girl. And was in the doctor's office with her and just sort of heard in my heart, hey, you need to get checked out. I had been in the breast care sort of process and system for probably 10 years at that point from my breast had grown a lot of lumps over the years, and I had had a ton of lumpectomies from large growths that were benign over time, but I had sort of fallen off in terms of my 6-month checkups and was about 18 months behind on it. And so at the doctor's with her, I heard like, hey, you need to get checked out. Went for my appointment, had a mammogram, and that's where they saw some things there. And so just having that conversation with my oncologist, her knowing my history, we talked about, okay, what are all the options on the table? Lumpectomy was an option with radiation. And then we would talk about kind of depending on what the margins look like and what they saw once they got in there, what we want to think about something like tamoxifen as well, because mine was hormone, estrogen and progesterone positive. But once we kind of got in, and again, thinking about my history, thinking about the grade, so it was relatively aggressive, even though it was early stage. I decided I wanted to do the double mastectomy. I just didn't want to run the risk, again, just given my history. And my breast had been cut on so much at that point. I think I probably had already sort of detached from them in a lot of ways, just had lost feeling in them already at that point. And so my husband and I, we got together, talked about it, and that was a decision that we came to, and I don't regret it at all. I would rather sort of let go of them than to run and kind of have in the back of my mind the scare of anything else coming back in recurrence possibility.
So you were really young. You
I
had
was
a best friend who had a traumatic experience that really affected you, and you had some surgeries.
That's right. That's right. That's right. And I just, it felt like the right, I had a lot of peace around, it wasn't something that I necessarily grappled with. Like that felt like that was an easy decision for me. My best friend did not survive.
Yeah, it's okay.
Yeah.
That sucks. Yeah.
On Friday will be 5 years since she passed away. And I definitely credit her with me being here.
In your life.
Survivor's remorse is definitely there. We don't have any children of our own. And so you can kind of ask the questions of like, why her, why me? She left a beautiful baby girl here, who I love to death, but just, I definitely thank her because I was there with her through her journey, and kind of got prompted to go and take care of myself and follow up on the things that I had fallen off on. So
Wow. Well, you added another element too of science here. You had a grade 3 tumors, grade 3. Did you say? Yeah. So Dr. Winnie, can you explain that a little bit too, what that means?
So she brought up a great point. So there, even though DCIS is all stage 0, every DCIS is not created equal. And so you can have low grade DCIS or high grade DCIS or intermediate grade. And the higher the grade, the more, and then they also use different descriptors like with necrosis. You may have heard with chemotonecrosis, or they'll just say with necrosis. So the higher the grade, the more aggressive the DCIS is. By definition, it's still contained within those ducts. But again, if you were to leave it alone, or if you were to have a lumpectomy with narrow margins, or if you were to have a lumpectomy without radiation, then the chances that that DCIS could progress into an invasive cancer is higher. And so, you know, in 10 years, like Ricky always say, when your grandbabies have boobies,
Right.
I would love to be at a place where science can say, this person has a low grade, small DCIS, and she's 80 years old, we can leave it alone and we don't have to do anything. But this person is 34 years old and she has a large DCIS with necrosis, and she had a lumpectomy and the margins were all narrow. We know that probably even radiation isn't going to prevent that from progressing. Maybe she should have a mastectomy, right? So, so that's kind of, the grades can define the aggressiveness on a more of a molecular basis. Mhm.
Yeah, great, great. Great. Okay, Gwen, you want to go next?
Yeah, and you know, it's the amazing thing, totally. You never know until you're struck with this disease, how the garden variety and the far-flung range of cancers, even within DCIS. So I always say mine was good news, bad news, and good news. And the good news was that I found out, and that the bad news was that I had to make some tough decisions, and I went through the lumpectomies not once, not twice, but 3 times. And the third time was the charm, because after the third time I said, okay, I'm going to just go for the mastectomy. I am 67 years old. And so the question of the surgery, of the mastectomy versus the lumpectomy, was really weighing heavily on me. And honestly, the lumpectomies, even though I didn't like having between February 2nd and March 16th, 3 surgeries, each one of those lumpectomies were pretty, you know, in and out. And after the second one, I was grilling salmon that night, and which is crazy. But the point is that the idea of a mastectomy, I had to really factor a lot of things in my mind. The third time, I said, after this, I'm not going to have another lumpectomy, and it's just gonna, I'm just take it. I'm going. Mm-hmm. Fortunately, all the margins, you know, the margins ended up being clear. And the other good news was that I did qualify for intensive modulated radiation therapy, IMRT, which was 5 sessions. And so between a Wednesday, starting on a Wednesday and ending that next Friday, I was in and out. I was ringing the bell and getting my certificate in like no time. And I hear what you're saying about the survivor guilt, Tish, because I have kind of, you know, and I love Ricky and all of our sister breasties who we encircle and who encircle us. And I was feeling a little bit, what are you complaining about? You know, you've got this little early stage DCIS, as my surgeon said, it was like an ant farm running around in a bowl of Jello. And, you know, because the cells were so small and they won't stay still. And that's what made it even more challenging for the surgery. But I was feeling guilty because I'm like, what are you complaining about? You had precancerous, as you said. But the other news is that I now live a life of vigilance. This week I had 3 appointments with oncologists. radiologist in my primary care. And vigilance is the watchword for me from now forever.
So Gwen, go back for a minute because I was there with you and
Where?
I actually, you were one of the several doctor's offices I was kicked out of. Oh, well. But
And I love it.
but I went with Gwen to the doctor the first time and, I was challenging her with our Black numbers. We have a 39% higher recurrence rate. And she said, well, Gwen's cancer is not serious, that she's going to be okay, that to do a double mastectomy for her would be overtreating. And I said, well, how many Black women do you have you had recurrences? And she didn't want to answer me. And after my third question, I got kicked out. She's like, Gwen,
Are you serious?
oh yeah, for sure, right? What, right? I was
Well, actually, you didn't get kicked out. That was the second time, Ricky, and you were on the phone. And she actually said, you and her finish talking, and I'll come back when you finish.
right.
So it
that's
wasn't quite kicked
That's
out.
right, that's
but-
right. Yeah, that's right. I forgot we went with you in that, yeah, but she wasn't having my interrogation. But what led you to that first decision about your lumpectomy? Like what led you to that decision, the first lumpectomy?
Well, I think the
Not
first,
having known you were gonna have two more, but what led you?
yeah, I didn't know I was gonna have two more. And I
Yeah.
thought, oh, in and out, and it's a piece of cake. What led me to the first lumpectomy was fortunately with people like you and the support network of so many women and sister breasties, I just felt so fortunate because I've been able to tap into that. So I did a lot of homework and I went to the lumpectomy, the first one, with the idea that I thought it would be one and done. I had no idea how tricky the margins were. And also, I will say this to all of you and to everyone listening, we did get a second opinion, right, Ricky?
We did.
And I'll tell you, what made me go for the second one is Ricky's surgeon who walks on water, and I loved her to
Dr.
death.
Regina Hanson.
She said if she needed breast surgery, she knew my surgeon. She said, Gwen, I would go to her. So when I got that kind of, I said, okay, even though she didn't kick Ricky out, but even though she said, you talk to her and I'll come back later. When Regina said that sort of sealed it for me that, okay, let's move forward with the second one because I was not feeling the second one. So.
And then you had a third.
Then I had a third. And the third, you know why I had the third? My sisters huddled with me, my blood sisters. And they said, well, listen, you've kind of gone this far. If you get this third lumpectomy and you still don't have the clear margins, then go for the mastectomy, but give it one more time. You've gone this far. And I was there already, but hearing that and hearing someone say what I was working around in my head was really important. So that's
Okay.
why I did it. 1, 2, 3.
Got it. Dr. Lena, can you explain margins?
Yeah, so you know how we talked about the ducts and the lobules? Well, if you think about operating, most invasive cancers present as a lump, like what you think you're going to feel a lump. And so if you think of it as a marble or an
Right.
almond or something that's round. And so as a surgeon, if you want to take something out, it's easier to take something out that is round or that is oval and to get a clear margin around it. But if you think about the breast ducts, like I said, if you imagine them, it's like, it's like the branches of a tree or the stalks of a grape. And so if you have cancer that instead of being a ball is growing along all these little digits, and then as a surgeon, you're trying to take it out, but you don't want to take out too much because you don't want to deform the breast, then that is how you can end up having positive margins. And so if you imagine it, it's almost like if you look at it, if you take a DCS and you cut it in cross section, you have lots of little dots of cancer as opposed to a ball of cancer. And so if one of those dots is touching where you cut, that's a positive margin. And then if you have positive margins or very narrow margins, the risk of recurrence is higher. And so, you know, I think what Gwen brings up and what Tish brought up, that difference in decision making, I mean, there's so many factors that go into deciding whether you're interested in a lumpectomy or mastectomy, but a couple of, you know, kind of clear cut ones are, if you're an A cup breast and you have a DCIS that's in multiple branches, you might not be lucky like Gwen and be able to have 3 lumpectomies, because maybe by the end of one lumpectomy, you already have some deformity to the breast. And so, I mean, you could have more lumpectomies, but they would be deforming. Whereas if you have a larger breast and, you know, you could remove an entire segment of the breast without potentially deforming the breast. So I think that that's important as well. But I think that it's interesting to see how different people, depending on where they are in their life. Tish said, you know what, I was done with my breasts anyways. I wasn't that attached to them. You know, some people are more worried about the extensiveness of a mastectomy. Some people are like, you know what, I don't want to have more surgery than I need to have. So it's interesting how different people will try to make one or the other work, or it can accept one or the other off the bat. And then sometimes nature forces our hand and we have to, you know, maybe go the other route.
Yeah, I know, because I would have been the itty bitty titty committee version. That's what they used to call me. All right. Christina, tell us your story.
Okay, so like I stated earlier, I started having problems after I was breastfeeding and I was in my 20s. So fast forward, I kept on going to the doctor over and over and over again, just because I was just, you know, my nipples were inverting. It was just a lot of symptoms. Fast forward to 2015, I ended up having a pulsating vein, a lot of pain. I go to the radiologist, and the reason why I'm telling this is because it's so significant to advocate for yourself. I went to the radiologist. He had an order for a mammogram and an ultrasound. He informed me that there was no need for an ultrasound, and I had dense tissue. I got the paperwork back. It stated, you know, dense tissue. You didn't need an ultrasound. Come back in a week if you're still hurting. I did that. Still nothing was done. From 2015 to 2019, it progressively got worse. The nipples were no longer, because I was always told, well, if the nipples are coming out, it's fine, you know, long as they're coming back out. Breast cancer doesn't hurt. You're young. It was so many different, you know, things that they told me. And here it is, I'm having now discharge coming out my breast. It's just so many things, and enlargement. So I go to another doctor. By this time, I find a lump. And this is 2019. And the doctor was like, she's an African-American doctor. And she's like, if you get denied, you come back and see me because you should have got an ultrasound in 2015. Fast forward, they did the ultrasound. They compared 2015, 2019, the same calcifications that showed them where the DCIS was the same pattern. They were telling me that truthfully, before they even found out, they were like, well, they did the biopsies and they came back benign. And then I said, no, something is wrong. And so she said, well, there's some calcifications in a little area that looks like a shadow. I don't know if it's cancer though. It could just be a shadow. You don't want me to keep on cutting on you, do you? I said, absolutely. We're going to do this again. Yeah. So I went back, and that's when I got the phone call that in fact, they found it in the calcifications in the area that was like a shadow was atypical hyperplasia. So I went to my doctor's office. I had my team of people, my mom and my husband and my sister, and she was going over various things with me about, you know, where it was found. And I was like, well, my God, that's half the breast. Like, you might as well just take the whole thing. And she said, well, you could get a lumpectomy. She was very thorough. She has a whole notebook and she goes over everything with the diagram of the breast. She shows you where it's located. And she said, I said, what's survival? Because that's where my mind was going. And she said, well, you know, survival for cancer, pretty much, you know, the 5-year for everything. So I was like, my husband asked a good question, which was recurrence. And when she said recurrence, she gave me a model of if you do a lumpectomy, this could be your percentage. If you do a mastectomy, it could drop it down to 2%. 2 to 5.
What were the percentages? What were the percentages?
Oh, so for what the percentage that she gave me for lumpectomy was, I think, 10 to 15% with the radiation and yeah, the lumpectomy and tamoxifen for
That it
5.
would come back, that it would come back, 10 to
Yeah,
15.
It was
Okay.
like 10 to 15% that it'll come back. If I did the lumpectomy radiation, I think it was for about 4-6 weeks because I had grade 3. And then it was the tamoxifen for 5 years. But she said, you know, of course, if she didn't feel comfortable, it could be a little bit longer because it was like throughout that whole left breast. So when I heard that, my husband kind of spoke for me. He was like, cut them off. And I was like, hold on, let me make the decision. It's my breast. So we went over everything and I said, okay, I'm going to go ahead and do a double mastectomy. I said, now my reasoning not only is about recurrence, I feel like my right one is changing like when the left one started back in, I don't know, almost 2 decades prior. I said, it's starting to change. Something's happening over there. So we need to take both of them. So she took both of them. She came to me. She said, you know, I try my hardest to listen to my patients. She said, I'm glad because initially they had wanted to wait 6 months to bring me back in after the first set of biopsies that were benign. And I pushed and I was like, no, 3 months max. And she said, come back in 2. So she said, I'm glad you pushed me. And, you know, you spoke up. She said, the other thing that I'm glad that you did was stand up for yourself and say you want a double mastectomy. She said, because your right breast, you would have been back within a year. She said it was changing. She said it wasn't precancerous, but it was a lot. She just said, you know, kind of like a lot going on. I did have POSH. So it was a whole lot that was going on in my right breast as well as of course, my left one. So I did that. I did the double mastectomy and I wanted to have reconstruction and to have a little bit of so-called normalcy back in my life. And I was okay with that. But what happened was from the time of the double mastectomy to my second surgery, I was sick as a dog. I could barely walk. I was just having a lot of complications. And I ended up having to go flat because she said, what do you want me to do? And I said, well, if I'm too damaged, just make me flat. And I woke up and I was flat. And she said, you had too much damage. She said, you definitely have breast implant illness and you have capsular contractor. And I had like a grade 4 capsular contractor.
What is that? What is capsular contractor?
When the scar tissue is basically forcing, I didn't have implants at the time, but my body couldn't even take the expander. And it was pushing it completely out of my chest.
Yeah, a capsular contracture is when, so basically when you have an implant or an expander, the body makes a capsule around it. And if you have a reaction, that capsule can start to constrict. So if you imagine putting a balloon in a bag and then tightening up the bag so that the balloon then is being deformed. And so sometimes women will notice when, if you've had a mastectomy and you've had reconstruction, that your implant starts changing shape. And sometimes it starts feeling tight or it's uncomfortable or it hurts. And so it can happen, like you said, with just the expander.
Yeah, it did.
Let's explain expander. So an expander basically is put in when you have the mastectomy and to help you stretch your skin afterwards. And then every couple of weeks you go in and they blow it up like a balloon
Right.
to get to be able to put the implant in later. Right. Did I say that right?
Yeah, right.
So yeah, so it twisted, it contorted. It was, you know, in the front of my chest at one point, and it was like coming up my chest, the expander was. And it was very dark, hard, and it was literally coming out of my chest. And I couldn't get the operation in April because COVID. So I had to wait till May. So every day it was progressively getting worse. I could hear fluid shifting and it looked like I was burnt on the front of my chest. And she went to cut me open and it popped and it went everywhere. And yeah, so I woke up and she was like, you lost a layer of skin. If you want to try something different, we can. She said, I'm not going to put an implant back in you. She said, but we can talk about other options, or you could go see, you know, another physician. But she gave me very much a lot of information, and I waited and I said, you know what, I'm going to be okay with me, and I'm just going to be flat because I was over it at that point. It was very traumatizing.
Right, right. And you know, you can get reconstructive surgery for the rest of your life if you choose to do something differently, right?
Absolutely. Yes.
A lot, there's a law in place for that. Well, thank you guys. Whoa, lots of stuff going on here. Okay, Heidi with the hearts.
Heidi
like-
with the heart.
I need that.
Hi, everybody. Thank you for having me. So my story, I'm a veteran. So I went to I had just been approved to go to the VA hospital. And interestingly enough, I had just found my biological mother. And subsequently, from finding her through her obituary in a Google search, I found my grandfather who was still living. And so through finding family members, my uncle and my grandfather, I learned that my mother, both my biological mother and my grandmother, both died of breast cancer. So I still didn't, and they are Ashkenazi Jewish, I still didn't know anything about breast cancer in that way to have it click for me in any way. It was my grandfather who urged me, like, you're a veteran, you should be getting, your medical care at the VA. So apply for it. So I applied, got the appointment, and that was the first time that I was able to check the box of, is there any family history of breast cancer? Because I didn't know prior to that. So my doctor was like, let's just get your baseline. Let's just see what's going on. I was 44 at the time, and 44, 45. And I just didn't think anything of it. I just didn't. I always say now, breast cancer doesn't affect you until it does, right? So I didn't think anything of it, and I went and had the mammogram, and then it was more phone calls like, well, we need to bring you back in. We need to look some more. And that's when I start hearing things like atypical ductal hyperplasia was the initial thing that I was told. And then I was called back by the radiologist and told that it was DCIS. And the words I heard, and this is all bringing back memories, was, oh, pre-cancer, to have a lumpectomy, you're young. And so I was like, well, if it's pre-cancer, it's not cancerous. It's not cancer yet, then why do I need to do anything now? Like, I don't even want to go down that road. And I remember the radiologist saying to me, you're young, just get this taken care of and, move on. You won't have to worry about it anymore. So I talked to my husband, I agreed to have the lumpectomy. That was in December 2017. And my mind never connected with breast cancer awareness, pink ribbons, breast cancer survivor. Like, I was like, one and done. Okay. I heard her say, we have clear margins. I'll see you in a year. And so I didn't connect at all with the breast cancer movement at all. It wasn't until the following year where I am a diabetic and my blood sugars were bananas. So I went back to my PCP, and the problem with the VA system is there are certain things that can't be done at the VA hospital, so they send you out to the regular community. Well, there's no communication between the doctors that you are being seen by in the community and the VA doctors. So when I went back, went in for a diabetic problem, my doctor said, my PCP said, well, what's happened since I've seen you last? Why is your A1C so far different than it was 6 months ago? Did you move? Are you sick? Have you been sick? Did you stress? What's going on? And I said, oh, I had a lumpectomy. And she was like, what? So she went through my records and she said, no, you need to be BRCA tested. You've got a strong family history. We need to do something about this. So all of 2018, it was tests here and appointments there. The VA is very, very slow. And originally I was denied the BRCA test. So my PCP said, there's more than one way to skin a cat. I'm going to send you to an oncologist. The VA had done none of this. So I'm going to send you to an oncologist. My oncologist said that what she did was, she said, they shouldn't have denied you. You're half Jewish, and it's, prevalent in Jewish people. So she highlighted my Jewishness, which I really didn't know anything about, and kind of downplayed me being an African-American woman to get an approval for me to have the BRCA test. So it was approved. I'm BRCA negative. And so I then here again thought, okay, I'm finished. I'm good to go. And so they set up an appointment for me to see via Zoom, see a genomist. And her question to me was, why do you want the BRCA test? And I was like, duh, because I want to know my status. Like, why am I here? And the way the information was given to me was like a ton of bricks was dropped on me. She said, it doesn't matter. I had never been told this. She said, it doesn't matter what your BRCA status is. Your lifetime risk calculated by the oncologist is 58%. The way I calculated, this was after my lumpectomy, where my mind was set on, I'm one and done, like no pink ribbons for me. She said, the oncologist rates you at 58% lifetime risk, and I have you at 62%. So what's the point of you?
Why?
Just because of my previous diagnosis, my paternal family history, as well as my maternal family history. So that was why she came up with the numbers. But this was before I was sent, okay, go back to the lab. You can have this was her line of questioning. Like, you have to have either increased surveillance or a mastectomy, regardless of your BRCA status. I had never heard that before. So it kind of stuck to the air out of the room. Like, I didn't expect that at all. I had set it up in my mind. I'm BRCA negative and I'm going on about my business. And so
Wow.
I was like, so she said, now that you've been given that information, why do you want your BRCA test? And I was like, well, I guess I want it because I have 5 children, 3 daughters. That she said, okay, good answer. It's waiting for you at the lab. Wow. Fast forwarding, that was December 2018. Fast forward. The VA is just one of my goals is to really work with the VA. I was sent to see the general surgeon, and the general surgeon, very prior military as well, was very, as a matter of fact. So what are we going to do? If you're going to go flat, I'm your surgeon. If you want reconstruction, I'll send you out in the community. And at that point, I was just so stunned that I was like, I don't want to do anything. Like,
right.
And he said, that's not an option for you.
Can I say something? I'm appalled, and this goes to Ricky's point. So you could get the BRCA test because you had Jewish heritage, but if you were African American, it wasn't that important. This goes to why Ricky is always fighting and slugging it out with these doctors, right?
Definitely. Yes, definitely. And it's funny that you bring that up, because if I say that in non-melanated spaces, then it said, that's not true. That couldn't possibly be the reason. But we as melanated women, African-American women, women of color, we live this every day. We live this disparity as it relates to breast cancer. We know the numbers. So
I love that word, non-melanated spaces. I've never heard that before. I'm writing that down. I love that.
So the VA got real funny, and he said, I'll send you over and you can explore your options of reconstruction. And things then moved very, very quickly. I wanted reconstruction. I was told all my options. That's when I was introduced to the deep flap reconstructive method and sent out to the community. Fast forwarding, my surgeon is a breast cancer survivor here in Atlanta herself. And I had made the decision to have the double mastectomy with immediate reconstruction because I just couldn't see my lifestyle and my children. I couldn't see myself waiting a whole nother, like waiting the time, as knowing how slow the VA is, waiting the time for results. I felt like I would live my life from result to result, from result to result. It took the whole of 2018 to go, have all the biopsies and the ultrasounds and the MRIs. And it just was such a long drawn out 2018 to culminate in, the BRCA test in December of 2018. So I made the decision, and I remember crying, just kind of at my pre-op appointment, breaking down in tears and saying, but I don't have cancer. Why am I chopping off my breast? Why am I doing this? And my surgeon's response was, cancer is like a gun at your back. It's coming back for you. We just don't know when. And so it was it was such a hard time for me to wrap my mind around, but I don't have cancer. Like, I had the lumpectomy. What am I doing here? And so I ultimately made the decision, and things went fast from there. I had the double mastectomy with immediate deep flap reconstruction, May 31st, 2019. And that's when I was like, okay, I'm a survivor, and where's all the pink ribbons? Well, I was mad at pink ribbons for a while, but I didn't want anything to do with pink or
We'll
pink
give you a
ribbons
pink
or
ribbon
anything for
anyway.
a while.
Yeah.
So
Wow. Gosh. I have no words. I don't even know what to say. Like, look at all these. So this is just, 4 of you guys. What does our world look like? Everybody has a different situation, a different story, different doctors, different perspectives. It's really crazy. And so it helps me understand a little bit, though, and help me with this, Dr. Lena. Doctors come in and say, okay, here are the things, here are your options, because they're seeing this variety of all these things that could possibly happen to so many women. They've got to put into buckets, into categories, right? And try to fit you into one of their spaces to tell you what to do. But at the end of the day, it's really your decision. I mean, you are the CEO of your own health. So how do you figure out what to navigate? And we are all the victim of the information we have in front of us. Right? I mean, with my triple negative, my doctor, it took me a year to figure out that she had only had 2 cases of triple negative, and both of the women died in 9 months. And so all of her biases with how she treated me were because of her personal experience with my disease. Right? And I realized she doesn't know anything. For God's sake, we got to get some help, girl. So, I mean, I think we're right. That's what I did. I had to go advocate for myself and find a doctor who knew what she was talking about. Thank God for that. But I think that, it's really hard. Every situation is really hard. I mean, Dr. Lena, how do you even navigate this?
Well, so, I think that doctors should be like, okay, I'm going to give you advice, like, of all the options, right? So for DCIS, the standard of care is either a lumpectomy followed by radiation, not a lumpectomy without radiation, but a lumpectomy followed by radiation versus a mastectomy. And that's with or without reconstruction. And then beyond that, then patients really have to determine. And so that's the hard thing, right? Because 20 years ago, people weren't telling women, you make the decision. They were just saying, this is what you need, this is what you're going to get, and that's it, right? But women, we want to be empowered. We want to be part of that decision. But sometimes it can be overwhelming. I mean, even as a physician, even as a breast surgeon, when I was going through my treatment, I kind of just wished I wasn't a breast surgeon, because I was like, I just want you to tell me what I need. Like, I don't want to feel like I'm responsible for the decision. But then in the end, I think that something that helped me counsel my patients and helped me as I was making my decisions is, if everything goes well with one of the choices you make, right? So Gwen's first lumpectomy, or starting out like Tish with a double mastectomy, then that's great. But when you're making these decisions, what I try to tell patients is, what if things don't go the way you expect? What if the worst thing happens, right? So you have a positive margin and you need a re-excision, or you have a lumpectomy and you decide, I'm having a lumpectomy and I'm refusing radiation. And there are some people where that's not completely crazy, but again, the standard is to have lumpectomy followed by radiation. There's actually a trial, that's kind of an aside, but there's a trial looking at which DCISs may be able to be observed rather than, operated on or excised with radiation. But that's an aside. But my point is, if as a patient, you're trying to make a decision and you think, okay, best case scenario, this is what I would choose. And I'm okay understanding that, okay, if I choose a lumpectomy and the margins are positive, I might go back, or I might eventually need a mastectomy, then maybe a lumpectomy is reasonable for you. If you're the kind of person that's like, you know what? I think it was Christina that was talking about the recurrence rates that she was quoted. You know, some women would rather die than lose their breasts. I mean, I've definitely had
Yeah.
those
Oh,
patients.
yeah, I've had those conversations. I've had
Right?
those
And
conversations.
so for those women, if you say you can have a lumpectomy, your recurrence rate is 20%, 10%, they're like, I'll take that chance because I may live the rest of my life and with my breasts. So if it recurs, then I'll deal with it then. But to some other women, you know, a lot of younger women, a lot of women with children, they're like, you're telling me that I can control my recurrence rate and decrease it from 10 to 15% to 2%, then I'll take that. So in the end, I guess what I'm saying is, because patients have such different opinions as to what they value, what's important, what they fear the most, or what they fear the least, I think that if you take all of those things into account, and then I really do think that, you know, what you're doing, Ricky, having advocates, having other women
Right.
that look like you, that have had experiences like you, that you know, whose worlds are similar, so you don't feel like you're walking into this world
Right.
of, well, I don't feel like I'm a part of this world, so even if I go to this support group, maybe their experience has nothing to do with, you know, what I would be comfortable with. So I think that patient advocates really do help, because, you know, people, you know, like, not everyone wants to walk in and have someone show them their mastectomy scars or their lumpectomy scars. But sometimes just talking to other people, well, how did you decide? Or you had 3 re-excisions. How did you decide to go forward with a mastectomy? Or, you know, so there's, the science is clear. It's not as advanced as we would like it to be. We would like to know, you know, if you were someone like Gwen and someone told you you have a DCIS that's low grade, that's probably never going to progress, and if you have a lumpectomy alone, you're good, right? In 10 years, hopefully that would be what we would have, that amount of information from the molecular analysis of the cancer. But right now we don't have all that information. So you kind of have to take the lumpectomy followed by radiation versus mastectomy, and then apply it based on, you know, what is most important to you and what the hardest thing for you to lose is, you know, whether that's having bigger surgery, whether it's having, you know, anesthesia, more anesthesia, whether it's having reconstruction. And then that's another thing that I think was brought up that's important, is going flat. I mean, I don't know if you guys have heard, but there's a huge going flat movement. Huge going
Yeah,
flat
huge.
movement.
Yeah. We did
And
a show about it, and there, you know, it's a thing. It's, I mean,
it's a thing, and a lot of people are fine with it. I had a double mastectomy, and I also, you know, my kids were young. I go to the beach a lot. I paddleboard like Ricky. And I was like, you know what? The silver lining, right? We talk about the silver lining
Right.
sometimes. You know what? I'll just get some nice little perky implants, and then I don't have to wear a bra, and I'm good to go. Well, sure enough, I ended up having a rupture, and I ended up having both of my implants removed, and I now am flat. And you know what? I think a little bit like Tish said, I was done. You know, I did not need, and Christina said it as well, I did not, initially I thought I wanted that silver lining, but when it didn't work out perfectly, I wasn't going to keep going on and on trying to figure it out. What Heidi had a flap, and that would have been my option at that point, because I had a mastectomy with radiation. So once you've had radiation, you can't, yeah, it's hard to have implants, but they tried with me, and then, but once that doesn't work, you can't just go have another set of implants after that. So I would have needed a flap. And I was like, you know what, to me, that's, for me, too much surgery. I don't want that much surgery. So, you know, it's so personal. But it's nice to have coaching. It's nice to have coaching so that you can navigate, you know, like Heidi, it sounded like it was pretty traumatic. Like you didn't understand. How did I go from?
Well, for me, everything happened so fast. Like all this was coming at me so fast. I had to make these decisions so quickly. Literally was told. So I literally was originally scheduled for surgery in July of 2019. And then it was moved to June. And then with 2 weeks notice, it was, the VA is changing their insurance provider. Here's your surgical team. And the only day that we have on the calendar to get this done is May 31st. And if you don't get this done May 31st, then we don't know when you'll get it done because we have to find you surgeons. And I had already done my homework. Here in the South, I had already, from here to Texas to wherever I thought the VA would send me, there weren't a lot of surgeons that were skilled in deep flap. So my options were limited. So I literally had 3 weeks. I had 3 weeks from your surgery's in July. No, we're moving it to June. To the beginning of May, I was given a phone call that your surgery date is May 31st. And this is the day you have to have surgery. So everything for me, I didn't even have a chance to really soak in what I was still stuck on chapter, but I don't have cancer anymore. I was still on that chapter where I was still like I was already moved forward to like 4 chapters later, like you're at the
You're
second now,
advanced.
sweetheart.
Wow.
Yeah.
You know, Ricky, if I can say something as we're talking about the conversation, you're absolutely right about all of the factors. There is really, age is a tremendous factor when you're young and when you're older.
Right. And if you have
And-
kids,
Right.
If you have kids, absolutely. For me, being 67, I mean, that was a big driver on whether I would go with a mastectomy or not. And even just looking at the recurrence rate and all those things. The other thing is I've never had problems. A lot of my fellow sisters have had cystic breast, oozing. I mean, when hearing Christina's story, I've never had any problems with my breast prior to that. So, you know, you're going to take a risk. You're going to, and the risk, no matter what you do, there's going to be a risk here or there, you know? And I think I factored in, my age was a big factor in my decision-making to not go for the mastectomy. So
I think with my doctor, just to piggyback off what you're saying real quick, my doctor was so good when she first came in. She said, this is your journey. We go as fast and as slow as you want to go, but I'm going to give everything to you. And when she did that, she broke down even about, because I said, what should I do? You know, give me some information. She broke down age. She broke down if you want to have children again, if you want to breastfeed. Like she broke down everything so delicately and hit on everything. And plus her mother had just come out of having breast cancer. So she was able to give me different perspectives. And I thought that was really good, on top of even telling me about trials that were available. But she didn't suggest I do that because I had a grade 3. So.
Wow. Wow.
And the risk benefit ratio, I think, is what both of you are referring to. The risk of doing bigger or smaller surgery versus the risk of having more anesthesia versus the risk of recurrence. And to every person, you know, that's a little bit different. But I think age does play a huge role.
Yeah. Val, you know, our co-founder's in the chat. She's saying she thinks there was a study for DCIS patients to select endocrine therapy and surveillance versus surgery. That she said it was called the COMET study. Have you heard of that, Lena? And she thinks they didn't enroll enough Black women, of course, but.
Well, there is the COMET trial, and I don't know that it's done. I believe they're still recruiting. And it's to look at whether observation, but again, there's very strict criteria, and I don't have all the criteria off the top of my head, but you know, high grade, large DCIS is probably not in the group of people that would be offered to enroll in that trial, right? That trial is probably for the low grade, small DCIS, without necrosis, that sort of thing. And like I said, it would be great if we had a crystal ball, we could tell which DCIS is going to recur or progress and which isn't, but we're not there yet. And so these trials will begin to help answering those questions.
Right. Well, and also, you know, the study that was done for a lumpectomy plus radiation is equivalent to a mastectomy was done in Sweden.
Yeah, and some of these trials, I mean, these trials that were done over 20 years ago, you know. I mean, smaller studies have been done, but the problem is when we talk about evidence-based medicine, which is what we want, right?
Right.
It takes a long time to accrue enough patients, as you know, Ricky.
Right.
But also you need to have the follow-up, enough years of follow-up, and then you want them to be randomized. And so these trials aren't easy to perform, and therefore, you know, we operate off of really old data sometimes. And
Yeah.
so it would be
Yeah,
great to
that's all I have.
modernize that data, but,
And with Black women in the data, hello, right?
and to
Yeah.
have the right diversity in the data is
Yes.
exactly.
Yes.
Dr. Lena, can I ask you a question? Can you say more about high grade DCIS with necrosis? And you've mentioned that designation a couple of times. I did have necrosis, but I don't recall my oncologist giving me insight into that other element. Can you speak to that?
Well, it's so unfortunately, we're still stuck in, it's called histological. So the way it looks under the microscope is the way this DCIS is being described. And so high grade is the way it looks under the microscope, and with or without necrosis or chemotonecrosis is also something that the pathologist can see under the microscope. You know, like when we talk about triple negative cancers, when we talk about, you know, HER2 new, all of those kinds of things, those are biomarkers. And as we get better at finding those markers that are relevant, then we're going to stop looking at the histopathology as much. Do you understand? Because the histopathology is only as good, it's only so good. But when we can find the biological, are we good? The biological markers, it'll be more helpful. But Tish, I don't want you to worry because you had a double mastectomy. And so I guess what I'm saying is if you have a large DCIS with necrosis, the risk of recurrence, when we say, okay, maybe the risk of recurrence is between 10 to 15 or 20% with radiation after a lumpectomy. If you have a mastectomy, you're decreasing your recurrence rate because you had a big wide excision. So you shouldn't leave this conversation thinking, oh, well, I had necrosis, so now my risk of recurrence is higher.
No.
That's kind of thinking about the risk of recurrence if you have a lumpectomy. And then when people bring up the COMET trial and maybe having observation instead of having radiation or plus or minus endocrine therapy, if you have any of those factors that make it more likely to be more aggressive, then you're not going to be a candidate for those, you know, minimal, less aggressive treatments. Does that make sense?
Yeah. No, it does. I thought for the audience that clarification.
Yeah, just to clarify. Yeah, that was a
Just
good
because
point.
I didn't get that clarification in my conversations. It was noted that there was necrosis, but not the, okay, what else does that mean? I guess
Right.
she figured that she kind of spoke to that in talking about the it being more aggressive. And so we want to be thoughtful about how we think about treatment, but just wanted to kind of clarify that for people, that because I think that is an element that's important for people to know as they're thinking about their decisions and what they want to do for treatment going forward.
Yeah, so we're kind of out of time, but I would love for you guys. I'm sorry, Dr. Lena, go ahead.
No, it was me. I was just going to
Oh,
ask.
sorry, Christina.
No, I was going to ask really quick. I don't know if doctors, every doctor does something different, but I know I had sentinel lymph node biopsies because especially I had such large areas and it was a grade 3. But is that something that all doctors should do, or it just depends on what their findings are? I was just wondering if you could clarify that.
Again, that's something that doctors can discuss with their patients, but the whole point, so even if you have a biopsy that shows DCIS, there's always a chance there could be invasive cancer somewhere else in the abnormal breast tissue, right? So if you're going to have, no one does sentinel nodes for lumpectomies for DCIS, but if you're going to have a mastectomy, then you'll never be able to go back and do a sentinel node, or at least not the standard sentinel node. So the reason for doing a sentinel node in someone that's having a mastectomy for DCIS is so that if after the fact the pathologists find that there was some component of invasive cancer, your axilla is already staged. Does that make sense? So
Can you explain sentinel node to our audience? Just
okay, so a sentinel node is the first node that would drain a cancer in your breast, okay? So if you have invasive breast cancer, your axilla should always be staged. So they should look at the sentinel node while you're having your surgery to determine if the cancer has gone from the breast to the lymph nodes in the armpit. And of course, that's important because it could dictate additional treatment. So typically, if we had a crystal ball and we knew that your DCIS in your breast was 100% only DCIS, you wouldn't need a sentinel node if you had a mastectomy. But the problem is if you have a mastectomy and then they find a small little portion of invasive cancer, they want to go back and do a sentinel node, you've kind of eliminated the lymphatic
Yeah.
mapping by having had the surgery. So that's the reason that we do it. I would say that most specialized breast surgeons probably offer their patients a sentinel node if they're having a mastectomy. And I think personally it's the right thing to do. It's what I
Yeah.
would want if I had a mastectomy. And so if you're considering a mastectomy for DCIS and it's not being offered to you, then I think that it's a very reasonable thing to bring up as a question. And again, I would guess that most specialists are doing sentinel nodes for mastectomies.
Thank
I
you. for-
remember, thank you. I remember when they do the pre-surgery thing where they shoot the dye to find the sentinel node. And I
Mhm.
remember going to sleep, going into anesthesia, thinking, I can feel that thing moving. Like I knew going in that it was
Wow.
lymph nodes, and it was, but I could feel it. I could feel I don't know, whatever was going on with the dye, I could feel it going someplace.
Wow.
Yeah.
The first thing I said when I woke up was, okay, within my lymph nodes. Of course, everybody lied to me. My mother, everybody lied to me, but it wasn't 7 out of 10. But anyway, we're out of time. But you guys, can you just give like your one sentence blurb to someone who gets diagnosed today with stage 0? Like, what would you tell them? Christina,
Have grace and allow yourself to be vulnerable.
Tish,
Advocate for yourself, make the right decision for yourself.
Heidi.
Tish took what I was gonna say, so I'll just
Okay,
second
say it
that.
again.
Advocate for yourself, ask lots of
Absolutely.
questions, and yeah, ask lots of questions.
Right. Gwen,
I would say embrace the journey fully, and in that embrace, take in all of the support that you need along the way. And that whole 0 thing, don't get hung up on the number, focus on the journey and where you're going, not from the diagnosis, but after the diagnosis.
awesome. And Dr. Lena,
I would just say that, DCIS is very treatable. It's very curable. There's lots of different ways to treat it. And so to, advocate for yourself, like everyone said, and do your research, but to be very hopeful and, that there are silver linings and that you'll get through it.
whoa, thank you so much. Thank you guys so much. What a conversation. We need to have more of this conversation happening. But I so appreciate you. And I so appreciate you, Doc, for coming in today.
course.
And being here with us. And so we're going to be on
And
one more.
we appreciate you
Yes.
and all that you do.
We're trying, honey. And we're going to be on again one more Sunday for October, and that back to our regular Wednesdays, we're on Wednesdays, but one more Sunday to go. And, still Touchtober, but, thanks for everybody and all you do, and advocate for yourself every day, be your own CEO, and I'll be healthy and take care. We'll see you. We'll see you Sunday at 3 Eastern, and then back here next Wednesday at 6. We're doing lobular next Wednesday at 6. So,
Okay,
That'll be
yeah.
good.
thank
So,
you.
Resty love.
Thank you.
Resty love.
Thank
Thanks
you.
to our sponsors. Thanks to all of our supporters. And thank you so much. See you soon. Resty love. Bye.
Bye-bye.
Bye.
Bye.